fluid, intraretinal fluid, the information that you the prognosis. So, Dr. Himanshi will be presenting today the biomarkers in the diabetic macular edema.
Uh, Hailing from Shimla and from Mandi, Himachal Pradesh, and she'll present on. She has worked with us since the last 3 weeks, and she will. She has seen many interesting cases and done many intravitreal injection and retinal lasers. And now she will present on OCT biomarkers and diabetic macular edema. Day to day, we were seeing many patients in our OPD with diabetic macular edema, and the decision between anti-VEGF, steroids, and regarding the prognosis. So that's why we put together this topic for OCT biomarkers and diabetic macular edema. Over to you, Dr. Himanshi. Is my screen visible? Sorry. Yeah, the phone is my screen visible.
Morning. Today's topic is decoding the retina and the OCT biomarkers in diabetic macular edema. So, what are biomarkers? Biomarkers is amalgamation of the two words biological and marker. So basically, it is a characteristic that can be objectively measured and it can be evaluated as an indicator of normal biological, pathological, or pharmacological response to a therapeutic intervention. So, what is the role of the biomarker? Biomarkers enable the treating physician to tailor a personalized treatment to each patient's individual disease and need. It also helps to explain the prognosis to the patient. It also helps us to decide between the anti-VEGF and the steroids. And since OCT biomarkers are the one which provide us a live histopathological report of the retina, so it limits the number of the invasive and the costly intervention. Now, the first biomarker that we are going to do is the central subfield thickness.
Diabetic macular edema. So, any newcomer in retina will know that any central subfield, if the central subfield is increased, then we should inject anti-VEGF. So, but what happens is ETDRS has found that 66% of the patients, in spite of injecting anti-VEGF, in cases of increasing central subfield thickness, did not, in 6 monthly injection, did not increase the visual acuity. So that's why the role of the OCT biomarkers take. So the central subfield thickness has increased. So we see the OCT and we inject monthly and we tell the patient that we need anti-VEGF injection. But the patient here, they want only the vision. No matter what you say, no matter what you explain, the patient will be concerned only about the vision. So, ETDRS says 40% of patients will respond to the anti-VEGF, the treatment name, but 32 to 66%, the DRCR net protocol data is there, 32 to 66% of the patients will not respond to 6 monthly anti-VEGF injection. So that's why then we need for the OCT biomarkers. So biomarkers are there are small those markers in the OCT which predicts the response to the therapy. Yeah, so that's why the our topic, that's why we put together this topic, OCT biomarker. Yeah, go on, Dr. Thanks.
The first is the central subfield thickness. In 26% of the patients, there is paradoxical visual acuity, which means that even with the increase in the central subfield thickness, the patient still having a good visual acuity of 6 by 6. So it does not represent the actual prognosis. It is not an actual predictor of the final visual acuity, although it may look good statistically. So as Sir said, only 40 to 50% patients achieve significant improvement in the visual acuity after anti-VEGF treatment. In the rest, 30 to 60% cases, edema still persists with reduced visual acuity even after the 6 months injection.
Okay. Come on, that's it. Mouse pointer is not- pointer that's hidden. That's pretty good. Continue.
So, 30 to 60% patient, edema persists with reduced visual acuity even after the 6 monthly injections. So, so so when the 60% of the patient are not able to achieve the good visual acuity, are we truly justified in treating all the diabetic macular edema patients with a rigid one-size-fits-all monthly VEGF regime? So I think it's a time to move beyond the one-size-fit treatment, and we have to tailor the treatment according to the patient's need. So why central subfield thickness is not enough? Because as I told earlier, because in 26% of the patient, paradoxical visual acuity is seen. That is, in spite having thick macula, the vision is good, 6/6, and in spite having a normal thickness, the vision is poor. So so instead of the central subfield thickness, the intact ellipsoid zone or in the good photoreceptor integrity is more important as compared to the thickness of the retina. So the take-home message is that don't treat the OCT number, treat the patient, and we have to look beyond the CST.
So that's a very important point regarding. So I want to ask something like this. The concept regarding the paradoxical visual acuity. If taking a situation with diabetic macular edema, so the central subfield thickness with 6/6 value. So would you inject or would you observe? Like the different concept are different opinions from the. So the protocol B it suggests that if the vision is 6/6 and the central macular edema is there, then we can observe only the metabolic parameters we need to control. This was given by protocol B that the vision is 6/7, 6/6 or 6/7.5 or better, then we can observe. Then there is no need for anti-VEGF injection. Yeah. So, thank you.
Now,
Yeah.
so the next biomarker is the intraretinal cystoid spaces. Intraretinal cystoid spaces appear as the round or ovoid hyperreflective cavities within the retinal layers. It indicates the fluid accumulation and breakdown of the blood retinal barrier. Their size, number, and location correlates with the disease severity and visual prognosis. Presence of the intraretinal cyst is a hallmark feature of the diabetic macular edema activity. A larger cyst that is more than 200 micron and involvement of the outer nuclear layer are associated with a poor visual outcome, whereas reduction in size, cyst size and number on the follow-up OCT indicate the better response to the treatment. Identifying active inflammation. Active inflammation in the retina is indicated by hyperreflective foci and subretinal fluid. So first of all, hyperreflective foci. It is seen as the hyperreflective dots within the retina, which represent the activated microglial cell. The absence of HRF at baseline correlates with the vastly superior visual outcome. So the presence of hyperreflective foci at the during the baseline, it indicates a bad prognosis. And second is the pearl necklace sign. It means that the pearl ring of the hyperreflective foci makes a continuous group around inside the cystoid spaces. They act as a precursor to the hard exudate, and they are a major red flag for the sudden visual loss. Then third is the subretinal fluid. Subretinal fluid appears as a dark space or hyperreflective space under the retina, and it is associated with the active inflammation. Now,
basically, biomarkers, they are divided into two categories. One is the inflammatory biomarkers, where it is driven by the inflammation, where it suggests the markers of inflammation. And second category is the biomarker indicating macular edema. So as Dr. Himanshi mentioned that markers for inflammation are hyperreflective foci, hard exudates, then there is the pearl necklace sign is there, and the subretinal fluid. Subretinal fluid initially was supposed to be the marker of predictive response to the anti-VEGF therapy. Now, the recent studies have shown that subretinal fluid, that sensory detachment, has increased levels of cytokine, that is interleukin 6. So it is responds well to the steroid therapy, like a Dex implant. Yeah, thank you.
So, so now the so now we know that if there is high burden of the hyperreflective foci and subretinal fluid, then a study indicates that 86% of the patients have achieved resolution with dexamethasone implant as compared to the anti-VEGF therapy, where only 50% of the patient achieved the response. Hyperreflective foci, as we discussed earlier, they appear as the intraretinal hyperreflective dots, and there is then hyperreflective choroidal foci. When hyperreflective foci migrated from the retina into the choroid layer, and they lead to the disruption of the external limiting membrane and ellipsoid zone. Hence, the presence of the hyperreflective choroidal foci is a poor prognostic marker in terms of the visual acuity. Subretinal fluid. As we said earlier, earlier it was predictor of the anti-VEGF response. So now we know that anti-VEGF subretinal fluid plus hyperreflective foci indicate that patient would benefit better from the steroid implant as compared to the anti-VEGF. So as the result from the RESTORE trial and the RISE and RIDE trial, the presence of subretinal fluid alone indicates a excellent prognosis for the visual outcome. Is it, sir? If it is alone, sir.
Anti-VEGF therapy, but if it is associated with hyperreflective foci and your hard exudates, so then it is a marker for intravitreal steroids or a Dex implant. So in the hyperreflective foci and hard exudate, the size is smaller in hyperreflective foci. So in OCT, we don't have back shadow. In hard exudates, we have back shadow. Yeah.
So now the bridging retinal processes. Bridging retinal processes indicate the residual neural element that connects outer and inner retina, that is molar cell and bipolar cell. So these are vertically, thank you. These are vertically oriented hyperreflective lines in the cystoid, and the bridging retinal processes represent the residual structural connection with cystoid and may influence the treatment response. So basically, if the bridging retinal processes are present, it means that is still some residual neural tissue is present, and there are better chances of improvement in the visual acuity. Pearl necklace sign we have already done. Now, disorganization of the retinal inner layer, also known as the DRIL. DRIL affecting 50 or more than 50% of the 1 mm central retinal zone was associated with the worsening of the visual acuity. So dexamethasone implant have the potential to ameliorate the DRIL. So now what is DRIL? DRIL is basically failure to identify any of the boundaries of the ganglion cell layer, inner plexiform layer, complex inner nuclear, and outer plexiform layer. ELM disruption or loss of ellipsoid or IS-OS junction. So, when we talk about the predictor of the final visual acuity, if the baseline ELM integrity is good, then it is a good predictor. It is a good predictor of the final visual acuity after resolution of the diabetic macular edema. It is graded into three classes. Grade 0, when there is no disruption of the ELM and ellipsoid zone. Grade 1, when there is ELM disruption, but ellipsoid zone is intact. Grade 2, when both ELM and ellipsoid zone is disrupted. Third biomarker is the parallelism. It is a rather new biomarker in which the subfoveal area covering the photoreceptor layer are skeletonized, and the orientation of the segmental lines was termed as parallelism. Photoreceptor layer status at the fovea include the continuity of the ELM inner segment ellipsoid line was studied. HRF migration and microglial activation. So hyperreflective foci, how to differentiate between the hyperreflective foci and hard exudate? First of all, on the basis of size. Hyperreflective foci are small dots, less than 30 micron in size, whereas the hard exudates are larger in size, that is more than 30 micron. And second difference is that there is no backshadowing is present in case of the hyperreflective foci, whereas backshadowing is present in case of the hard exudates.
So that is one of the important biomarkers.
The next biomarker is the giant cyst at the fovea. Large ONL cysts, which are of the size more than 200 micron, have a negative impact on the macular function, and it predicts the worst visual acuity outcome even after the anti-VEGF treatment. Size of the cyst is correlated with the extent of the macular ischemia, and both horizontal and vertical increase of the cyst increase with the severity of macular ischemia. Another point to be noted is that the prediction of the visual acuity also depends upon the fact that how much of the neural tissue is remaining between in the cyst. If there is very little or no neural tissue is remaining in the cyst, so then it indicates a poor prognosis.
As you can see in the image, it compresses on your photoreceptor layer. When it compresses on the photoreceptor layer, the conduction hampers. So when the cyst, there are three classifications. The size they have mentioned in the literature as less than 100 micron. The small cyst, the intermediate size as 100 to 200 micron, and the largest cyst has more than 200 micron. So when it compresses the photoreceptor layer, there is the conduction is not hampered, so your visual prognosis is decreased. And the bridging retinal processes plus the cyst is very important. If the bridging retinal processes is there, it means the remnants of the Muller cells are there, the conduction is there. And third thing is the residual tissue, as Dr. Himanshi mentioned, residual tissue between the cyst and the inner retinal layer. So these three things are very important. Yeah.
Now, the therapeutic diverging matrix. Inflammatory markers are functionally sign of the chronicity. So, standard anti-VEGF treatment is preferred when there is edema in the inner retinal layer only, when the patient is presenting with the baseline presentation, and If there is any traction or membrane is present, then the surgical or vitrectomy is preferred. In corticosteroid or dexamethasone implant is preferred when there is present of the hyperreflective foci. If there is high baseline increase in the CST, hard exudate or pearl necklace sign is present, subretinal fluid is present, and there is severe DRIL presentation. These are the conditions when we prefer corticosteroid over the anti-VEGF. Now, what are the OCT biomarkers which predict the steroid response? When there is rapid reoccurrence post anti-VEGF or steroid treatment is noticed in when there is a hyperreflective dots, foveal eversion, which is a sign of persistent traction, intraretinal hyperreflective material, and the disruption of the ellipsoid zone. Poor visual outcome despite good anatomical response is seen in the DRIL, ELM, ellipsoid zone disruption, and the hard exudate or cholesterol presented fovea. Now, what are the conditions in which the better response is seen to the steroid? One, if at the beginning of the disease hyperreflective dots are present, high central macular thickness, hard exudates, and DRIL. These indicate the response that response will be better with the steroids as compared with the anti-VEGF. Now, the combined presence of the hyperreflective foci, pearl necklace sign, DRIL, and progressive hard exudate indicates a highly chronic and inflammatory environment. So, in this chronic state, anti-VEGF resistance is usually there. So, the drugs with a higher drying effect, especially with the dexamethasone implant, are highly preferred to target the inflammatory cascade. So, all of these inflammatory states like hyperreflective foci, DRIL, pearl necklace, hard exudate, we have to shift to the dexamethasone implant as compared to the standard anti-VEGF therapy. Now, the prognostic spectrum matrix. Isolated markers must be synthesized to predict the final visual acuity and manage patient expectation. Positive outcome is indicated if there is intact external limiting membrane, if there are bridging processes are present, which indicate the neural tissue, if there are strict outer retinal parallelism is present, if the choroid is thick, and if there is decrease in the central subfield thickness. Whereas the poor functional outcome is indicated by disruption in the inner retinal layer, if there is disruption in the external limiting membrane, if the subfoveal hard exudate which are present subfoveally, and if there is the choroidal hyperreflective foci, plus there is cyst of the size more than 200 micron with remaining tissue. So the clinical decision matrix, when to give anti-VEGF, when to shift to that dexamethasone implant, and when to do the surgical intervention. So if the subretinal fluid is present, if there is inner retinal edema without any massive cyst, and patient have intact external limiting membrane, ellipsoid zone, there is minimum HRF, then we should proceed with the monthly anti-VEGF injections. But if there is high baseline CST, hyperreflective foci is present, DRIL is present, hard exudate present at the subfoveal location, pearl necklace sign is present, then we should switch to the dexamethasone implant to target the chronicity. And surgical intervention. Surgical intervention is required when there is a visible tractional element and there is a taut posterior hyaloid membrane. So, vitrectomy is done to relieve the mechanical tension. In this case, a medical therapy alone will not be sufficient. So, the dynamic nature of the diabetic macular edema, we have to, as we said before, we have to look beyond the central subfield thickness. It may indicate the volumetric response, but it is not the predictor of the good visual acuity. So whenever we are assessing a patient of the diabetic macular edema, we have to evaluate OCTs from the top to bottom. We have to evaluate every OCT spatially from the traction to the vitreomacular interface down to vascular health of the choroid. So individualized therapy. Biomarkers do not always work in perfect tandem. So we have to use them comprehensively to manage the patient expectation and to change the treatment between anti-VEGF, steroid, and the surgery. Now, as the OCT biomarker of the diabetic macular edema. So, as we discussed earlier, central subfield thickness. Should I repeat? So, master tailored treatment flow chart. This is the diabetic macular edema is not a static disease which can be treated with a single drug. It's a dynamic multifactorial condition which require personalized pathway routing. So first of all, obtain the baseline scan and measure the central surface thickness. Then we have to go through whether there is inflammatory signs are present or the structural signs are present. Inflammatory signs are hyperreflective foci, pearl necklace, and structural signs include the DRIL, parallelism. So then we have to set the patient expectations based on these markers, and whether we have to start the anti-VEGF standard anti-VEGF procedure, or we have to target the corticosteroid implants. So conclusion is that every patient need a personalized treatment rather than one treatment fit all kind of thing.
Never treat the printout alone. Never treat the printout like if we have a printout in our OPD, then the central surface thickness of this. So never take always go to the OCT machine and or on your computer, scroll the whole OCT. What I mean to say is scroll the whole OCT and then personalize the treatment on patient to patient basis. Because we are mentioning that OCT biomarkers such as hyperreflective foci, neurosensory detachment, these are inflammatory biomarkers are there. So we should switch to steroids. But in all, we should see the patient as a whole. Like what is the status of the patient? Like I mean to say that whether he or she is a steroid responder or not. If it is a treatment naive patient, if he or she is a young patient. So the side effects of the steroid cataract versus glaucoma, we should keep in mind that also. And also the metabolic parameters does his metabolic parameters permit the kidney status, the sugar status, or the neurological and the cardiac status. So all we have to treat the patient as a mind. So that's why the tailor-based approach and never treat the OPD alone. Because we are in our OPD, we have seen in cases like one case I remember, we had, injected ranibizumab to aflibercept injection to ranibizumab injection. It was a case of vein occlusion, but the vision was 6/18 only. It did not improve much. So the vision did not improve much. So when we injected steroids, then like we looked at the OCT very carefully and very deeply, and then we found the inflammatory biomarkers such as the hyperreflective foci and the hard exudates, and even the DRIL we found out. So then we gave them an option of DEX implant or an intravitreal transitional. So with that, now the patient is doing a little better. So this tailor-based approach is very important. Treatment naive patient, my first line of therapy is 2 doses of anti-VEGF. If it is not 2 monthly doses of anti-VEGF, loading doses. If it is not responding, then you can switch to the steroid, the DEX implant or the intravitreal transition. Now, we have our senior ophthalmologist, Dr. Nipun sir with us. Even before OCT came into OCT जब इन्वेंट भी नहीं हुआ था सर तब से डायबिटिक मैकुलर एडिमा देख रहे हैं सर हम तो कहते हैं कि OCT है हमारे पास पता है कि एडिमा इतना है एंड ये सब बायोमार्कर हमारे पास OCT की वजह से तो पहले तो क्लिनिकल जो फाइंडिंग था क्लिनिकल जजमेंट इतना स्ट्रांग होता था कि सर के जमाने में तो सर से पूछना चाहूंगा सर जब आपके पास डायबिटिक मैकुलर एडिमा या डायबिटिक रेटिनोपैथी वाले पेशेंट आते थे तो हमको तो ऐसे क्लिनिकली आप क्या देखते थे हमको मैकुला में कुछ ऐसा लगता है तो हम पॉजिटिव की मदद ले लें डायबिटिक का बोला कि पहले क्लिनिकल जजमेंट क्लिनिकल वो बहुत इंपॉर्टेंट होता था, अभी भी क्लिनिकल जजमेंट, जैसे सर ने बोला कि पहले जब एंटी वेजेफ नहीं थे, बिफोर द एडवेंट ऑफ एंटी वेजेफ द लेजर्स हैड अ रोल, नाउ आल्सो फोकल लेजर हैज अ रोल, तो फोकल हैज अ रोल इन केसेस ऑफ non-center involving diabetic macular edema. Suppose we have a OCT with a non-center involving diabetic macular edema, center is okay, and then we see the clinical fundus picture. So, temporary to the macula, the fascinated with a microaneurysm inside. So that microaneurysm is leaking to cause the diabetic macular edema. So we do a focal laser and enlarge the microaneurysm. The location of the microaneurysm should be more than 500 micron from the fovea. So how do we do the focal laser practically? So what we do is we focal laser is the grade 1 burn we use. That is the just visible burn. We go to the periphery of the retina, titrate the burn. Like it should not be grade 2, the grade 3 burn. So depending on the power, we titrate the burn. It can come at around 40, 50 milliwatt or even at 100 milliwatt, depending on the machines also. Then we blanch the microaneurysm in the sustained retinal body. So focal laser still has a role in cases of diabetic macular edema. So now these are the 5 principles. Yeah, go on, Dr. Himanshi. Thank you.
So now 5 principles to carry into every clinic. Central subfield thickness is necessary, but it is not sufficient alone. We have to always investigate the tissue quality. Now, DRIL and ellipsoid zone integrity are the two of the strongest structural predictor of the final visual acuity. Dense hyperreflective foci plus subretinal fluid often signals an inflammatory phenotype that may respond better to steroids. And then we have to reassess phenotype after loading. Do not continue a failing strategy indefinitely. So if the patient is not improving, we have to change the treatment approach. We have to counsel the patient with structural damage honestly. That patient should be properly counseled and the expectation should be realistic. So this is everything repeating again. So clinical scenario.
Yeah. So we have fellows with us. So I want Dr. Pallavi, are you there? Dr. Pallavi would be joining us in the month of September and October. So there is I just jot down 2 important questions, 2 important like a quiz questions, so that we can understand this topic better. So we had a 58-year-old teacher from rural Rajasthan. So this was the OCT picture. Large central cystoid spaces involving the fovea intact, the outer retinal bands, and mild subretinal fluid was there. His vision was 20 by 80 on the ETDRS chart, and the scattered hyperreflective foci, and there was no definite drift, and the central subfield thickness was 458 micron meter. So I want to ask Dr. Lalita, so what will be your first line of treatment? And what regarding the prognosis? Is it a good prognosis or a bad, like a worse? So this is the OCT picture, 58-year-old type 2 diabetics for 12 years. And there is no drill, no definite drill, intact ELM and ellipsoid zone. And so this is will come to the first line definition of vision, treatment naive patient. So first line of treatment. But I would like to mention that there's a treatment naive patient. In this case of picture, the hyperreflective foci they have given just for the to confuse. So the treatment naive patient now first presentation of DME. So always treatment naive patient anti-VEGF is the first line of treatment. Okay. So if it is not responding to anti-VEGF in the after the second 2 doses, then you can go ahead with the intravitreal steroid. Or if the patient is, they're not mentioned in the phakic or pseudophakic, if the patient is a pseudophakic patient, then you can go ahead with the steroid. But the first line of treatment, even like for what I practice is first line of treatment in treatment in patient always an anti-VEGF to avoid the risk of steroid-induced increased IOP complications. Yeah. So this with single biomarker most strongly reassures you about the vision potential in this eye. This is the intact outer retinal bands and the absence of DRIL. Okay. So what is the most likely visual prognosis? Favorable because there were no DRIL and outer retinal bands intact. The second case, 64-year-old farmer has a recurrent diabetic macular edema and vision was 20/100. Therefore, 4 prior anti-VEGF injections. This is the OCT picture. There was a DRIL in this, disrupted EZ zone in this, thin outer nuclear layer is there. So, does improved CST guarantee visual recovery when DRIL and EZ disruption persists? So, I want to ask Dr. Himanshi, like what would be the treatment of choice in this patient and what regarding the prognosis?
So the next step should be that we have already given the 4 injection of the
Yeah.
anti-VEGF. So we should switch to the steroid implant.
Plant, So as Dr. Himanshi mentioned, because of the recurrent, we have given already 4 anti-VEGF. DRIL is also present. There's a disruption of the. So the next implant has the potentiality to ameliorate DRIL. So we should switch to the steroid implant early. So A option is ruled out. C option is ruled out. With C option, we can observe when there is a persistent diabetic macular edema. There is an entity called as persistent diabetic or a recalcitrant diabetic macular edema. In spite of many injections, anti-VEGF and many steroid injections, the vision is around about, say, like the vision is constant. It is not improving. Then we have only one option for the strict metabolic parameter control and to just observe on topical NSAIDs drops. So as Dr. Himanshi mentioned, consider early steroid implant because of the DRIL and the recurrent diabetic macular edema. So this is the nutshell. Measure CST, phenotype the eye, choose the first line of agent, reassess at 3 to 4 months, and the personalize the long term because we are looking at the long term visual gain. Always counsel the patient. So see, diabetic is a lifelong disease. So always counsel the patient that treatment will go on for long and it depends on your duration of diabetes and the control of the metabolic parameters. Not only the diabetes, not only the blood sugar, the lipid profile, and even the renal parameters. So thank you for your attention. Thanks a lot, Dr. Himanshi. Any questions to Dr. Himanshi or Murthy? Right. Anti-inflammatory development is one of every here we have Dr. Himanshi, any idea? That is asking about the where drugs, anti-inflammatory drugs are coming up. Just for it, yeah, there are advanced glycation and product, and there is some first container for advanced digestion product. There are reaction there can look at the chemical protein and other interleukin, which can the barrier better, the better the barrier better. If they got it, or if they are develop drugs and after the idea for last. बहुत अच्छा point, very nice point mentioned by the advanced glycation end products. So newer therapies are coming up for advanced glycation end products to ameliorate the diabetic retinopathy. The one point I remember is that lipid lowering drug that is the phenylfibrate they used to prescribe in patients of heart phenylfibrate drugs they used to prescribe. Any more questions or any opinion? So thanks a lot. So it was a very Thanks a lot. It was a very nice session on OCT biomarkers and diabetic macular edema. So it was a very nice question. Any questions you have, please. I'll put this on YouTube also. You can ask the questions on YouTube or mail to me at nipun.bagricha@gmail.com. Thank you. Thank you, Dr. Nipun. जी जी सर